So today, let's go ahead and continue where we left off last time. Last time we were talking about different types of CVAs, right, where you have an occlusion or a hemorrhage that's affecting your blood vessels. We closed by talking about arteriovenous malformations. When does this happen in a person's life? These things. When did these start to form in a person's life? That. Yeah, it's during development. So this is going to be just malformed blood vessels, and it happens during embryological development, fetal development, and into adolescence. And an individual might not even know that they have any problem at all until later on in their life when all of a sudden one of these blood vessels ruptures. These are highly prone to rupture, and so it would result in a hemorrhagic stroke. And then we talked a little bit about pronator drift, where you have your hands supinated, pointing to ceilings, and then you have them close their eyes. And then if all of a sudden their arm starts to move off and drift off to a side, then that's pronator drift, right? So as soon as their arm starts to go pronated and drift off to the side, that is pronator drift. And it could indicate lesions to different parts of the brain. It could be the cerebellum, but it could also be part of the sensory pathways. It could be part of the motor pathways as well. So it could involve cortical spinal tract, upper motor neurons, things like that. Okay, but you can also use it for cerebellar type of damage. And I forgot that video link doesn't work anymore, so I'm going to have to replace that at some point with something else. All right, now we're coming to one of my favorite parts in neuroscience, and it has to do with speech. Okay, so you have two major speech centers, which we kind of already talked about already a little bit, but we have the Broca's area, which is going to be part of your frontal lobe. It's going to be the more anterior portion of your speech centers, and then posterior to that is going to be Wernicke's area. Now, Wernicke's area and Broca's area both work together. Broca is going to be part of your motor function. So like whenever you're producing speech or producing words, that's going to allow for motor control of like your mouth, your oropharynx, larynx, etc. Whereas Wernicke's area is all about comprehension of speech. So speech interpretation, right? So when somebody's talking to you and you're understanding what they're saying, that's because Wernicke's area is coming into play. Okay? Think about Wernicke's area as being like a little bit further behind. It's not, it's kind of closer to the parietal lobe, and the parietal lobe is mostly going to be sensory input. So you can think about Wernicke's area as sort of being where you have like the sensory input of the information from speech, and that's where you're integrating it into the brain. And then the motor component, which is closer to the frontal lobe governs a lot of your motor function, right? The precentral gyrus. And so think about the Broca's area as being associated with the motor control of speech. Now, if you have damage to these areas because of trauma or maybe a stroke or maybe a hemorrhage of some sort, then your speech is going to be affected. So what's going on with, actually first before we talk about that, most people are going to have these speech centers on the left side of their brain. It's the majority of people, about 90%. And a lot of that has to do with handedness. So if you're right-handed, it's definitely going to be on the left side of the brain. Even if you're if you're right-handed, it's going to be on the left side of the brain. But sometimes if you're left-handed, it's still on the left side of the brain. But some people who are left-handed are going to have these speech regions located on the right side of the brain. So it really just depends on the individual. So there's some variety in there. Now, if you have damage to the Broca's area, that's going to affect the ability for your ability to produce words, right? And so they call this a non-fluent aphasia, right? So they're not able to speak much at all. Their words are going to be extremely blunted. I'm not going to play the Broca's video here, but this is a video that I saw for the first time when I was in med school. And this is one of the reasons why I actually got super interested in neurology to begin with, because it's amazing to see how a neurological deficit can absolutely impact the way that you engage with the world. So let me actually play that video second. Let me play this other video first, because this is going to be more associated with Wernicke's area. So Wernicke's area, this is fluent aphasia, meaning that they can speak all sorts of words, but the words they say don't make any sense whatsoever. So let's play a video first on a guy that has Wernicke's aphasia. Make sure the volume's up.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today? We stayed with the water over here at the moment, talk to the people, for them over there. They're diving for them at the moment. They'll stay in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We will store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
the iPad that we were doing. Like here?
I'd like my change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them. Good. This girl was fairly good and happy. And I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for people, for us, other hands. Of what you get, but I talk with a lot of hands for him. Sometime. Am I talk of any more to say?
All right, thank you very much.
Thank you very much. I appreciate it. I hope the world lasts for you.
Thank you. It's been a pleasure. Bye-bye.
Have a good day.
I hope the world lasts for you. So, what's going on there? Do you think he actually understood what she was saying to him?
I think he understood it, but he totally meant something else every time he spoke.
So, the thing about people with Wernicke's aphasia is that they actually have a hard time understanding what people are even saying. They think they understand what the person's saying, but they actually don't. So they don't comprehend what's being said to them. They can't understand what's being read to them if they're reading pages, like words on a page. They don't really understand it, but they think they understand it. And then when they speak, same thing. They think that they're making sense when they speak, but they actually make no sense whatsoever, right? So think about Wernicke's aphasia. Think word salad. So they're speaking tons of words, but it don't make any sense, right? Okay, so that's Wernicke's aphasia. Word salad. Word salad. So I think about how you make like a salad. You got all these ingredients in there. You toss it all up, right? It's kind of like that. What's up?
Is there any similarities between like the words that people choose?
In terms of how they decide to speak? I don't know, actually. That's a really good question. This will be even more of a pressing question when we watch the Tono Man. So let me play a video of Broca's aphasia. Now this is, your speech is blunted with Broca's aphasia. So maybe think B, blunted speech, Wernicke's aphasia, W, word salad, okay? So here is the Tono Man.
However, we shall see how effective this patient is at manipulating his intonation of this utterance. The segments you will see are, first, a conversation about his upcoming move to a new house, followed next by a sample of his spontaneous automatic speech.
But tell me, why is it that you're moving, actually? Is it that because the kids have grown and the house is getting too big, or ready for a smaller place? It seems reasonable. Less to keep up. All your children are grown, right? How many children do you have? Can you count that out for me? What number is this? Right? Now let's count it out.
1, 2, 3, 4.
Nice. Well, since you did 4 so well, let's go for broke. Let's go up to 20.
What's up? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, One,
Isn't that wild? It's absolutely wild. So what's going on there? First of all, did he actually understand what was being said to him? Yeah, so he totally understood everything that was being said to him. Was he able to speak what he was trying to say? Not really. And I know, right? What happened when the numbers came up and he was able to actually count the numbers? Isn't that crazy? That throws you off. Why do you think that is? What's your theory on that? No.
That's like the earliest thing you learn.
No. Good guess though. So counting numbers comes from a different part of the brain. Up until you get to a certain point, remember he goes like 1 through 12, right? The moment he starts saying 12, that's when it shifts over to the language center, the Broca's center, right? And then when he's trying to pronounce anything beyond 12, now that's going to be the verbal side of the brain. So numerical processing, different part of the brain. Absolutely incredible stuff. So like I said, that when I saw that video for the first time, it absolutely blew my mind. So absolutely amazing. So anyways, Broca's area, again, this is the motor part. It's part of the inferior frontal gyrus. And there's going to be 3 portions of it. Debating whether or not I want to hold you guys accountable for this. Probably not. I think Broca's area just suffices for this class. But you got the opercularis, which is going to be the frontalmost portion. That's going to be associated with recognizing tone of voice. Then you have the triangularis, which is going to be the second portion over here. And that's going to be associated with translating. You can translate from different languages as well. And then you have the orbitalis. Okay, so the orbitalis is going to be motor area associated with the tongue. So anyways, I think sticking with just Broca's area for this class, I think is going to be good enough. So if you understand the difference between Broca's area versus Wernicke's area, you should be good. And again, Wernicke's area, sensory, right? It's going to be a sensory component of speech recognition and planning speech. And it's going to be part of the temporal lobe. And remember, the temporal lobe is also associated with what else? Yeah, hearing, right? So when you're hearing words, Wernicke's area is also going to be, associated with hearing and interpreting those words. And so if you do understand what somebody's talking to you, if you do understand what they're saying, even if it's like reading, if you can understand what they're reading, what's on a piece of paper, then that's going to be Broca's aphasia. If you don't understand what the words are, then that's going to be Wernicke's aphasia. Here's just something that's kind of interesting with some people who have aphasias. They can go into music therapy. And there's been incidents of individuals who are like professional singers, for example, and they would have these areas affected. But then when they would sing, again, different part of the brain was going to be associated with that. And so they're actually able to articulate the words while they sing. So let me just play it. Let's see how long this video is. Yeah, it's not that long.
Parts of the brain related to understanding speech or producing speech.
You say yes. His doctorate, Tier Memorial Herman, says patients who suffer this kind of stroke seem to regain speech and confidence back faster with music therapy.
So you can use those parts of the brain that were not injured to be able to create meaningful speech.
Your name is power. For Jeremy, music isn't just therapy. It's a big part of his life. He was worship leader at his church.
I speak Jesus.
He's singing this song from memory. Your name is healing. Although his journey is far from over, their faith is their fuel to keep going. Kathy is confident this is a recovery story.
He comes out with phrases. He said, "I love you" the other day when I didn't hear it for a while.
Those 3 words, music, to her ears. Stephanie Whitfield, KHOU 11 News.
So super cool. Super cool that you can do music therapy to try to help regain what was lost previously. So anyways, again, to summarize aphasias, right? Whenever you hear the term aphasia, this means difficulty in speaking, right? Impediments on speech. There's like global aphasias too. There's a couple other types of aphasias that we're not going to go into in too much detail there. So global aphasia would be like everything is affected, right? Speech comprehension and the production of speech. Causes, again, strokes, trauma, even infections, right? We're going to talk about meningitis in a little bit. People who get meningitis, even if you treat the meningitis successfully, sometimes the person will actually have permanent neurological deficits, which is like the scariest part of meningitis. Meningitis, first of all, can kill you really easily. Some people die from meningitis within like 24 hours. It's very intense, especially if it's bacterial. But even if you survive, sometimes people get permanent, damage to their hearing, right? They go deaf. Sometimes they might even have aphasia, right? Depending on the extent of the inflammation. Stuttering. Who was it? Was it someone in this class? It was you. I was talking about. Okay, so I actually looked it up. I decided to go ahead and put it in here. Yeah, because I thought it was kind of cool. So stuttering does involve many different areas of the brain. It can involve, they call it the cortico-basal ganglial thalamocortical loop. Okay, so yeah, that's a mouthful, right? So cortical basal ganglia. So cortex, right? Remember, you're planning things out within your cortex, and then it goes down to your basal ganglia. Right, basal ganglia helps to initiate movement and to inhibit unwanted movement, and then it goes to the thalamus, right? And the thalamus is a relaying center for a lot of different neurological activity, and then it goes back again to the cortex to allow the actual initiation of the speech. And so, some depending on what type of stutter it is, these areas could be affected in different ways. So, in the Broca's area could be involved in stuttering. Wernicke's area could also be involved, but then also the basal ganglia could be involved in stuttering as well. So I thought that was kind of interesting.
Prince Bohemond III, King Louis II of France, and the Byzantine Emperor Michael II all had stutters so pronounced that they were each referred to as the stammerer. So even if you have a stutter, you could be an emperor one day. Hey there, stuttering stallions. Jules here for D News. A stutter is a type of speech disorder when your speech is involuntarily broken up by repetitive sounds or blocks where you can't quite say the sounds you want to. More than 70 million people worldwide are believed to be stutterers. Some develop the stutter in childhood and it goes away. Others can develop it later in life. Boys get it more often than girls, and they're more likely to have it persist into adulthood. For a long time, it was believed that the disorder was psychosomatic, meaning that it wasn't related to a physical cause, but rather a mental block, like stress. Well, it turns out that's not quite true. A new study published in the medical journal Human Brain Mapping looked at 62 people with and without stutters, focusing on blood flow in an area of the brain called the Broca's area, which is located in the frontal lobe. They found that in people with stutters, there was less blood flow in this region, and blood flow in the brain is related to neural activity. The more severe the stutter, the less blood flow in the Broca. So what's so important about this part of the brain that it causes stuttering? Well, the Broca's area is associated with speech formation alongside another part of the brain called the Wernicke's area in the temporal lobe. They are part of the neural language loop and are both necessary to produce clear and concise speech. The Wernicke's area is the part where you choose which words you want to say and in which order. It's like a behind-the-scenes blueprint or a storyboard for your speech. This information is then fed into the Broca's area, which produces those words out loud.
So we already talked about all that stuff already. So if you want to watch the rest of that video on your own time, feel free to do so. I believe I have the link in your updated slides, right? Did I put them in there? I think I did. Maybe not. Maybe not. Anyways, it's in there. Okay, cool. So you can see that video on your own time if you want. So stuttering, it does involve those areas. So kind of interesting. Here's something else that's kind of interesting is hemi-neglect. And hemi-neglect is going to involve where you have like spatial awareness issues. And half of your perceived spatial awareness is going to be affected. So if you were to try to draw a clock, and you try to put all the numbers 1 through 12 on there, it's all going to be just isolated to one single area. Same thing if you try to draw a house, you're only going to draw like one half of the house. If you try to draw a cat, it's only going to be one half of the cat. And so it has to do with parietal lobe damage, where the parietal lobe is going to be involved in a lot of your sensory processing and sensory input. And so if you have parietal lobe damage, then you might get hemi-neglect. So that's a really, really interesting condition. Now, let's switch gears and talk a little bit about brainstem lesions. And like I said before, there's tons of different types of brainstem lesions, and I am not going to hold you guys accountable for all of them. But needless to say, there's a lot, and they can get pretty very nuanced. I think it's like more grad school level material. But the one that I really want to talk about here is going to be locked-in syndrome, mostly because it's so terrifying. Because what happens with locked-in syndrome is that you're completely consciously aware of your environment and surroundings, but you can't move whatsoever. Except for in the classical case, you can still move your eyes. Sometimes you can still blink. But there's also ones that are complete total immobility. So the total immobility form, you can't do anything. You do still have normal cognitive ability, though. You can still process thought. You can still think. That's the scary part about it, right? You're completely conscious. Yes? No, Stephen Hawkins had a condition called amyotrophic lateral sclerosis, AML, and that's an upper and lower motor neuron disorder. And we are going to talk about that in this class at some point. We'll probably talk about it in the motor section. So ALS, also known as Lou Gehrig's disease, that's what Stephen Hawkins had. And, if you've been following the whole like Epstein stuff with Stephen Hawkins, and I see people on like social media, like, did he actually feel anything? And it's like, actually, yeah, he did, because ALS is a motor neuron lesion, upper motor and lower motor. Your sensory input is preserved, including, that's how he has kids, he had kids. Yeah. So he had kids. He was able to still have kids, he would go to strip clubs and stuff, and totally wild. Yeah. Totally wild. Anyways, let's watch a little video. Digress
Today's
here.
video topic is the locked-in syndrome. Locked-in syndrome is a rare condition that affects the ability of an individual to communicate and move their body. Despite being physically paralyzed, the affected person remains conscious and aware of their surroundings. They may be able to communicate using eye movements, blinking, or other small movements. Causes of locked-in syndrome. Locked-in syndrome is caused by damage to the ventral pons region of the brainstem, which controls the muscles responsible for movement and speech. The most common causes of this damage include 1. Stroke. Stroke can cause damage to the blood vessels in the brainstem, leading to locked-in syndrome. The damage can be caused by a blood clot that blocks blood flow to the brain or by bleeding in the brain. Number 2, traumatic brain injury. Traumatic brain injuries, such as those sustained in a car accident or fall, can cause damage to the brainstem and result in locked-in syndrome. Number 3, degenerative diseases. Certain degenerative diseases, such as ALS, amyotrophic lateral sclerosis, or multiple system atrophy, can cause progressive damage to the brainstem, leading to locked-in syndrome. Number 4, drug overdose. Overdose of certain drugs, such as barbiturates, can lead to respiratory failure and brainstem damage, causing locked-in syndrome. Symptoms of locked-in syndrome. The symptoms of locked-in syndrome can vary from person to person, but typically include 1, paralysis. Individuals with locked-in syndrome are unable to move their limbs or body, but are able to move their eyes and possibly their head. 2, loss of speech. Individuals with locked-in syndrome are unable to speak or make any vocal sounds, but are able to understand spoken language. 3, retention of cognitive function. Despite being physically paralyzed, individuals with locked-in syndrome are able to retain their cognitive function and are aware of their surroundings.
So again, you can watch the rest of that video on your own time. Just for the interest of time, I don't want to spend too much time on that. But long story short, any sort of pontine damage, especially the ventral pontine area, that could cause locked-in syndrome. So extremely scary condition. However, some patients do recover, right? So you can actually make a recovery from locked-in syndrome. Yeah, so there's some stories about, like, actually go to the next one. This guy over here, he had severe locked-in syndrome, and then over time he actually started to gain back a little bit of function. So this is the guy, Jean-Dominique Bauby, I think is how you pronounce his name, but the diving bell and the butterfly. So really famous case of locked-in syndrome. He wrote the book, but like by blinking his eye. You had to have somebody like help him write the book. But that's, he was able to actually communicate his conscious, his conscious thoughts through blinking, and that's how he was able to actually get the book written out. So pretty amazing case of locked-in syndrome. And again, the causes of locked-in syndrome, usually it's going to be something like stroke, infections, tumors. He mentioned ALS, right? Just like, what's his face? Stephen Hawkins. And then trauma, substance abuse as well, drug overdoses. All those things can cause locked-in syndrome. So here, I just included 2 examples of brainstem lesions that can, you can start predicting some symptoms just by looking at which areas might be affected. So this would be where if the anterior inferior cerebellar artery was affected. So that's an ICA type of stroke. There's also a pica stroke, which is the posterior inferior cerebellar artery. But ICA, so if this area was affected right here, these are the different nuclei that would be affected. So think about what some of the symptoms might be. So you have, let's start over here. You got the spinal thalamic tract. What does that do? Is that motor or sensory? Sensory, yeah. Spinal thalamic. Okay, so it goes from the it's afferent fibers going up to the brain to the thalamus. Okay. What about the spinal? Well, let's skip that one. What about the cochlear nucleus? So that's part of cranial nerve 8. Huh? What? What sensory input would that be? It's cranial nerve 8. What does cranial nerve 8 do? Do you guys remember?
Was it like balance?
Yes, so part of that is balance. That's the vestibular part. And hearing. The cochlear part's going to be hearing. So you have the vestibular nucleus right here, and you also have the cochlear nucleus right here. So both your hearing and your balance could be affected, right? And then you could also see maybe potentially the facial nucleus would be affected. So this person would probably have what? Loss of hearing, difficulty with balance. They would also lose their sensation from the spinal thalamic tract, and they could also have paralysis of their face. So they might have dizziness and vertigo, nausea, facial weakness, numbness, decreased sensation on one side, hearing problems, and troubles walking because of imbalance. If you have vertigo, you're probably going to have a little bit of, even if you have sensory loss, that's going to probably affect your ability to walk a little bit. So there's like so many of these different types of strokes throughout the brainstem. That's the reason why I'm not including that in this class. This is like literally medical school level stuff. And so
I was freaking out.
No, I am not. I know. I am not going to test you on this kind of stuff. The only thing I'm going to test you on is just the pons. Like if you have like a pontine lesion, what does that cause, right? So here's another example. So this is the medial pontine syndrome. The artery right here, this is the basilar artery, and it goes right through the pons on the anterior side. And so if you had a branch off the basilar artery being affected, you could get medial pontine syndrome. So it's going to be on the medial portion of the pons. Look at the nuclei here. So you got cortical bulbar. Remember what the cortical bulbar tract does?
Isn't it temperature and isn't it the face?
It's movement of the face, okay. Right? So remember we had like the facial nucleus, cranial nerve 7 goes through the cortical bulbar tracts, right? That's going to be allowing for movement of the face. So it's motor function. So if the cortical bulbar tract is affected, then you wouldn't be able to move your face, right? Medial lemniscus is also part of your sensory input. That's going to be coming from your dorsal column. Then you have abducens nerve. What does the abducens nerve do again? Yeah, well, no, down and out would be trochlear. Abducens is just out, right? So it's lateral movement of the eye. So this would cause an ability to move your eye laterally, right? So your eyes would be, if you're, moving your eyes, your eye might stay fixed, right? Instead of moving laterally, it's going to stay fixed. So this person's able to move their left side, the unaffected eye, to the right, but then the right eye that's affected stays stuck, right? It's not able to move laterally. And then you would lose some motor ability on one side of the body. You'd get some weakness as well. So, like I said, I am not going to test you on these. This would be that would be super unfair for you guys. This class is already hard enough. Facial palsies. This I will test you on. So you definitely need to know this, right? So if your entire one half of your face is affected, should you be really scared? Should you like start really getting concerned that you're having a stroke? If your entire one half of your face, you'd be scared. You should be scared if only the lower quarter of your face is affected. If the entire one half of your face is affected, it's probably Bell's palsy, which is a lower motor neuron lesion. And that involves usually like an infection of some sort. It can be herpes. It could be infectious mononucleosis. There's a lot of different types of things that can cause Bell's palsy. But if it's the entire one side of the face, you shouldn't necessarily be too scared. However, I would still recommend getting a CT scan because it could be a stroke. You want to make sure you rule that out just in case. So why is that the case with a stroke where you have sparing of the top quarter of the face? That's because you have bilateral innervation. You have motor tracts from both sides of the cerebral hemispheres that are actually innervating one side of the face. So if you affect just one side of the brain from a stroke, the other side of the cerebral cortex also crosses over and innervates that part of the face too. So you're going to at least get one-sided innervation for that area. So that's why it doesn't get affected. Whereas lower motor neuron lesion, it's going to be outside of the spinal cord and brainstem. That's going to be involving the entire one half of the face. Again, it's usually going to be associated with viral infections, so upper respiratory tract infections. It could be due to herpes simplex. It could be due to varicella zoster. That's what VZV is. It could be EBV, which is Epstein-Barr virus. So different viruses can cause this. For whatever reason, pregnant women get this at a higher rate. Yeah, I don't know why, but it happens. One of my students said that this happened to her when she was pregnant. So super weird, super interesting. Good thing though is that usually it resolves on its own. Sometimes you have to take like a corticosteroid like prednisone or something like that because this is inflammatory mediated. And so to reduce the inflammation, you could take a drug like prednisone, but usually it's going to resolve on its own. And usually it takes about 2 months or so. Now, here's one thing that might kind of suck is that you might want to have to wear an eye patch. And the reason being is because if you get a corneal ulceration because you can't blink your eye, that can be extremely painful, right? The cornea is the part of your eye that you can actually, like, you can feel pain from, right? When you poke your eye, the cornea is like the dark part. So if you get a corneal ulceration from not being able to blink because that, blinking is what lubricates the eye, that could be a huge concern. So you might want to use eye drops and an eye patch if you have Bell's palsy. And again, corticosteroids for the treatment. All right, any questions on any of that stuff? All right, let's now switch gears and let's talk about the meninges, and we're also going to talk about cerebral spinal fluid, and then we're going to close out talking about the blood-brain barrier. But before we do that, has anybody seen this movie? All right, do yourself a favor, watch this movie. It's hilarious. It was made back in like the 80s, and it's making fun of like all the 80s rock bands and stuff. This is where I don't know if you've ever heard the my amp goes up to 11. I don't know. It's kind of, anyway, a great movie, Spinal Tap. So Spinal Tap, also known as a lumbar puncture in neurology. But like I said, do yourself a favor and watch that movie. I am always aging myself in these classes because none of my students have ever seen that movie. I had like maybe 2 students during my tenure here at GCU that's actually seen Spinal Tap. All right, so the meninges. The meninges are the regions of the brain. Well, it's the portion outside of the brain that protects the brain. Right? You got 3 major layers. You got your dura mater, which is going to be the outermost section. Dura mater translates from tough mother in Latin, okay? And it's going to be a really thick, tough, fibrous type connective tissue that helps protect the brain. And you're going to find that throughout the central nervous system. It's going to go from brain all the way down in the spinal cord. So if you go to the labs over here and you pull out one of the brains from the bucket, because we have several brains in buckets, if you pull them out, sometimes they'll still have the spinal cord attached. You'll see the dura mater going all the way down the entire length of the spinal cord. So super cool. Then below the dura mater is where you have the arachnoid mater. And as you can see from this image over here, this is a really nice image where you can see all the these little stringy-like substances, right? They kind of look like spider webs. That's where arachnoid mater comes from. It comes from like spider web, right? like arachnophobia, your fear of spiders. This is also where you find CSF. That's where you find your cerebral spinal fluid. It's going to be within the subarachnoid space. You're also going to find a bunch of blood vessels hanging out in there. Also, you have the arachnoid granulations that are these out pouches that come in contact with the sinuses of the brain. And that's where the blood, that's where you have veins, right? That's the venous system. So this is where CSF gets drained into. CSF leaves the brain and eventually gets drained into the venous system through these arachnoid granulations. And then below all that, you have your pia mater, and the pia mater is kind of boring. It's just like, you know, the innermost layer of the meninges, and it's the portion that's directly attached to the brain itself. So CSF, again, that's where you find it in the arachnoid, subarachnoid space, in the arachnoid mater. It's also going to be produced by a certain type of cell called ependymal cells. You find those within the ventricles. You find it in the fourth ventricle as well as the lateral ventricles, predominantly in the lateral ventricles, part of the whole like choroid plexus. And then they're going to, again, get drained out through the arachnoid granulations. So again, overall view here, you got dura mater, arachnoid mater, and your pia mater. Your CSF is found in your subarachnoid mater. Now, you can administer anesthetics through a lumbar puncture, right? When you're inserting a needle into either between L3 or L4 or L4 and L5, we call these either epidural blocks or a spinal block. Now, what's going on with an epidural? So epidural, you're going to lose all your sensation, and you're going to have a little bit of motor function still preserved. This could be something that you could get done if you're pregnant and you're delivering a child and you don't want to feel all that pain, right, from labor and delivery. So you can get an epidural. And then the onset is going to be a little bit slower. So it's going to take about 30 minutes for it to kick in. You can also do a spinal block. And again, that's going to be between L3, L4, or L4 or L5. And you're going to go in through the subarachnoid. You administer the shot, and it's going to be a rapid onset. Let me play a short video here of, I think they talk about here how to insert the needle.
In this video, we will demonstrate a technique to administer spinal anesthesia utilizing the midline approach with a pencil point needle in a non-obstetric adult patient. Understanding the anatomy involved in a spinal anesthetic is crucial. To review, the layers encountered as the needle goes through a midline spinal placement are skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, arachnoid mater, and then the subarachnoid space. Optimizing the patient's position is fundamental to performing spinal anesthesia in the sitting position. After properly positioning the patient in a flexed or slouched back posture, identify the patient's midline by palpating the spinous processes. To approximate the lumbar level, palpate the superior aspect of the posterior iliac crest. The line joining the two, also known as the intercristal or Tufier's line, is generally stated to identify the L4 or L4-L5 level. Using a 25 gauge needle, administer local anesthetic at the target site. It may be helpful to carefully use the local needle as a finder needle to identify bony landmarks. Next, place the 20 gauge introducer needle. While holding the introducer, insert the 25 gauge Whittaker spinal needle through the introducer. As you are inserting the spinal needle, you will feel different amounts of resistance. As you pass the ligamentum flavum, the resistance will increase. A tactile give will suggest that the needle has traversed the ligamentum flavum. At this point, Remove the stylet from the spinal needle to check for CSF flow.
And I'm going to stop it there. That's a very similar procedure as inserting the needle so you can get a CSF sample. And so they're going to check for CSF flow. If you're taking a sample of CSF, say, for example, your patient had meningitis, or you think they have meningitis, or they have like encephalitis or something else going on, this is how you would do it, right? So you insert those needles, and then you would be able to harvest a little bit of their CSF. So that would be one way for you to diagnose conditions like meningitis, as an example. Now, CSF is going to be, again, produced in the choroid plexus. And you got choroid plexus found within the lateral ventricles. And then you're also going to find ependymal type cells in the fourth ventricle as well. But the majority of your CSF is going to be produced within the lateral ventricles. And they're going to move through different openings as they course throughout the brain and then down into the spinal cord. So they're going to move through the foramen of Monro, for example, then down into the third ventricle, which is going to be the space right below the lateral ventricles. And then it's going to go into the cerebral aqueduct, which is going to be this region right here, kind of just behind the midbrain, and then eventually into the fourth ventricle. And then it's going to go all the way through down to the spinal cord. And then eventually it's going to kind of course its way back up to the brain again so that it can enter the venous system through those subarachnoid granulations. So what's the point of CSF? Now the brain, it's to kind of help let the brain float, right? The brain is going to be made up of a lot of adipose tissue, and fat basically floats over water, right? And so to allow buoyancy of the brain, CSF is going to help to basically protect the brain. So otherwise, the brain would just start to crush on its own weight, right? There's a freshly harvested brain that even one of my students actually harvested over the summer in the lab, and it's really, really soft. Like usually when they sit in like the preservative for a long time, they start feeling a little bit more tough. But this brain is like extremely soft because it was just like recently harvested. And if you set it down, it's just kind of like, it's all soft and it kind of like squishes a little bit. And so if you didn't have CSF to, keep the brain buoyant, then it would start to basically crush on itself. And then you're producing basically about 150 mLs of CSF, which is periodically being replaced. Again, here's your choroid plexus. The cell type is ependymal cells, or are ependymal cells. Those are the ones that actually produce your CSF. And the bulk of your CSF is going to be made in your lateral ventricles, but CSF is going to be produced elsewhere too. So you can get it in the fourth ventricle, even the third ventricle. So CSF can be produced everywhere. But again, lateral ventricles is where you get the bulk of the production. CSF, I can't remember the exact. Actually, let's pull it up real quick. I don't know what the exact makeup of CSF is. It's probably proteins and other kind of stuff. Glucose, proteins, lipids, and electrolytes. Yep. Good question. I should probably start including that in my presentation. I lost my spot. Let's go back to my spot. Right there. All right, again, this is the movement of CSF. So lateral ventricles. Then you have this is also, the intraventricular foramen is also referred to as the foramen of Monro. Then it goes down to the third ventricle, cerebral aqueduct, fourth ventricle, and then eventually it's going to make its way into the subarachnoid granulations. So here you got your arachnoid granulations, you got arachnoid villi as well. This is where now CSF can get drained into your venous system. Arachnoid villi, you'll find that in near the superior sagittal sinus. Right, superior sagittal sinus is what basically goes longitudinally, right? It's sagittal, right? So it's going right down the midline of the brain. And then the arachnoid granulations, you can see this on some of the specimens that we have in our lab. You can see all these little tiny bumps. It's on the superior portion of the cortex on both sides. So it looked like little fat granules, kind of. And here are all of your different ventricles. So we already kind of talked about most of those already. Now, something else you see when it comes to the movement of flow of things like CSF and whatnot, as well as like waste tissue, it's going to be part of the lymphatic system. So you guys took A&P, right? And so you studied the lymphatic system in your body, right? That's when you have extra fluid that gets basically filtered out of the capillary beds. Whatever doesn't get reabsorbed remains within the lymphatic system. And then eventually it makes its way back to the venous system. You also have something very similar in the brain, the lymphatic system. So the flow is just like the lymphatic system. You're going to have flow of the arteries towards the veins, right? And then it's going to go throughout the parenchyma of the brain. Whenever you hear the term parenchyma, actually, let me ask you guys, you guys know what the term parenchyma means? So parenchyma means the functional unit of an organ. So the lung parenchyma, it's going to be like your alveoli, right? That's where you get gas exchange. You talk about the hepatic parenchyma in your liver. It's going to be like all the cells that are actually engaged in function. It's not the stuff that's like the supportive type tissues or like the scaffolding of tissues. It's the actual functional unit of tissues. So you have CSF basically moving throughout the brain parenchyma, and it's going to kind of act as like a rinsing mechanism. So it rinses things out. Right? As you metabolize throughout the day in your brain, you're going to be accumulating lots of metabolic wastes, sometimes even like misfolded proteins, things like that. Those things need to get rinsed out of your brain. And this is one way that it gets done. It's through that lymphatic system. You also have microglia. We're going to talk about microglia a little bit later. Microglia are basically the macrophages of your central nervous system. They basically go in there and gobble things up. And they're especially active during sleep. Okay? So sleep is super important. That's why it's important to get, solid sleep at night. 8 hours, 7 hours, around there, right? Because if you don't get enough sleep at night, this whole process isn't going to work very well, right? There's actually been correlations between people who have poor sleep and neurodegenerative disorders like Parkinson's disease, Alzheimer's disease, right? Because a lot of those diseases have to do with accumulation of misfolded proteins, and those misfolded proteins get gobbled up and taken away from the brain during your sleep, especially, right? So get your sleep, guys. Here's another thing that's important about sleep. There was another study that was done, and I don't remember who did it, and I should probably look it up again, but it was a study that was done talking about what sleep deprivation can do, like the negative aspects of sleep deprivation. So if you get less than 5 hours of sleep, for every additional hour that you miss, it's equivalent to one alcoholic beverage. So if you get less than 5 hours of sleep, if you get 4 hours of sleep, that's like drinking one drink. If you get 3 hours of sleep, that's 2 drinks. 2 hours of sleep, that's like 3 drinks, right? And then on top of that, if you're operating machinery or driving a car, being sleep deprived is extremely dangerous. There's been stories of, those, when I was in my 3rd, 4th year of med school, I was reading about a resident that was like a 1st year or 2nd year resident. And, when you're working as a resident in the hospital, you're getting crappy sleep because they're working you like 90 hours a week sometimes. Horrible stuff. And this resident was sleep deprived while driving back home from a shift, fell asleep at the wheel and got into a car accident and died. There's even studies that show that I have to be careful saying this because I'm not advocating for one or the other, but it's safer to drive drunk than it is to drive sleep deprived. Because at least if you're drunk, you're still conscious. Whereas if you fall asleep, you're not conscious, right? Now you have you're driving 70 miles an hour with like 3,000 pounds just careening on the freeway and you're completely unconscious. That is extremely dangerous. So get your sleep. Sleep is super important. I know it's really tough when you're in college, right? I had many sleepless nights when I was in undergrad as well as in med school, but you try to get as much sleep as you possibly can. Hydrocephalus is where you have an accumulation of CSF in the brain, and it can be pretty bad.
CSF shunt involves insertion of a valve.
Before we go into that, so if you have hydrocephalus, some people are born with hydrocephalus. You can develop hydrocephalus as well if you have any sort of blockage, or even like brain trauma. Sometimes people get brain trauma, and then they start building up CSF in their brain there was this poor guy. He was like a Jamaican dude. He was here working on like a visa, and he was part of our neurology team. Like we're like, you know, he was one of our patients. And this dude was in the hospital for like 14 months in a bed in a coma because the guy was a construction worker and he fell from like 4-story scaffolding. He fell off the scaffolding, landed on his head, and he was like in a coma. I don't know if he had permanent brain damage or whatever, but he had severe hydrocephalus from the injury. And so he had to get this. It's called a peritoneal shunt, where they take a tube and they connect it to your ventricle all the way down into your peritoneum, so the CSF can get drained into the peritoneum. And this dude had to have this thing replaced often because it would get clogged up, and so the hydrocephalus would come back. So it's a horrible
A
condition.
CSF shunt involves insertion of a valve that regulates and drains the excess cerebral fluid from a patient's brain. The operation normally takes less than an hour, and it is a common procedure done by skilled neurosurgeons. Incisions are made to the head and abdomen. Tubes are then passed through the fatty tissue under the skin. A small hole is made in the skull to allow the ventricular tube to be passed into the lateral ventricle. The peritoneal tube is then placed into the abdomen to allow the fluid to drain. After surgery, the patient will typically spend up to 7 days in hospital to ensure the procedure has been successful. A far more effective solution exists in the form of an adjustable valve. This shunt is identical in every respect to the fixed valve, but critically allows the physician to make small adjustments to the pressure setting by using a remote magnetic programmer, eliminating the need for further invasive surgery and ensuring the best possible improvement for the patient.
So why is it drained back into the skull?
Because it can get reabsorbed once it gets into the peritoneum, right? It would be really bad idea to connect that to like a vein or something, because then you might get backflow of blood into the brain and stuff. Well, I mean, then you're exposing it to the outside environment, and then that could lend itself to infection, right? So that would be a concern. So if you go into the peritoneum, you have much like less risk for infection, but it does get clogged. So that's one of the unfortunate conditions that you have to deal with here.
Is the reason that it's like that it doesn't stop? What am I trying to say? Like the reason for hydrocephalus is because it thinks that it needs to like drain out damage.
No. So hydrocephalus just means that you have a blockage of the ability to drain the CSF out of the brain. And so if you have any sort of blockage, maybe to one of those, like, you know, like the foramen of Monroe or the cerebral aqueduct or one of those areas, if those get occluded for whatever reason, then like you start getting CSF in other parts of the brain, right? So there's lots of different types of hydrocephalus. There's other conditions that are caused by, you know, too much excess amount of fluid in the brain. But yeah, it's basically just a blockage. Yeah. So here's really bad hydrocephalus. Look at the size of those lateral ventricles, just absolutely huge, completely enlarged. So very, very damaging. And if you're a kid, that CSF has nowhere to go. So, it has nowhere to go, but the brain can still, or the skull can still expand. Why? Yeah, it's all cartilage still, right? So they like the brain, the bones in the brain haven't, or sorry, the bones in the skull, the bones in the brain, the bones in the skull haven't fused yet, right? So that's why you can get like old babies look like aliens when they have hydrocephalus, right? So crazy stuff. Anyways, blood-brain barrier. Here's the big thing to keep in mind here is astrocytes. Okay, make sure you know your glial cells. The astrocytes are the ones that are making up the blood-brain barrier. You're also going to get tight junctions in there, and it's extremely selectively permeable, right? It's not going to allow just anything to come on in. You also have your endothelium, right? So that's part of your blood vessel. And then you also have these things called pericytes. And pericytes are going to be spread out. They're going to be interspersed along the capillaries. And so these are all going to act together to basically prevent just whatever to come into the brain, right? So it's extremely selectively permeable. You're going to have special proteins to transport glucose, right? Because glucose is not just going to cross over the blood-brain barrier. You have to have transporters for that. However, certain things can just cross over. Oxygen, carbon dioxide, alcohol. Right? Alcohol can just go right on in. It's a very tiny molecule. So lots of drugs can cross the blood-brain barrier. Drugs that have a CNS effect, whether it's like drowsiness or maybe even like whatever, psychomotor agitation, any drug that can have a central nervous effect crosses the blood-brain barrier. So give me an example of an over-the-counter drug that crosses the blood-brain barrier. Yeah. So NyQuil is going to have an antihistamine in it, right? If I remember correctly. Doesn't it have Benadryl in it? Yeah. So Benadryl, great example, right? Benadryl crosses the blood-brain barrier, right? It has antihistamine effects in the rest of the body, but it crosses the blood-brain barrier as well. It's also going to have some like anticholinergic effects. So yeah, anything that crosses the blood-brain barrier is going to have a CNS effect. So what kind of capillaries do you see? You can see fenestrated capillaries. Fenestrated capillaries are going to have these little openings in them. So if you speak French, fenêtre is the word for window. So if you have some openings in there, you're going to find fenestrated capillaries, especially in the areas that are producing CSF. So part of the choroid plexus, within those third, fourth ventricles, even the lateral ventricles as well. Other areas that you're going to find fenestrated capillaries, you're going to find those in the hypophyseal, what's it called? The portal system, hypophyseal portal system, right? In the pituitary gland connected to the hypothalamus, right? So you're going to have the ability for hormones to be able to move freely between those two glands, right? Super important for that to happen. So you're going to have more fenestrated capillaries in those areas, as well as the pineal gland. So basically any sort of gland or something that's producing CSF, you're going to see more fenestrated type capillaries. So they're going to be a little bit more permeable and a little bit more leaky. So these are going to be the breaks within the blood-brain barrier. So here's another image of you got your astrocytes, which are making these little tiny feet, right? So they've got these little podocyte type contraptions, right? They are going to help to make sure that nothing is going to be crossing through or selecting what's able to cross through. So again, some drugs can cross the blood-brain barrier. Let's talk briefly about Parkinson's disease. In Parkinson's disease, one of the gold standard treatments is carbidopa and levodopa. So 2-drug combination, and there's a reason for that. One of the reasons is that you don't really want the dopaminergic effects to have an effect peripherally. You want it to have the effect centrally in the central nervous system, right? You want to treat the actual Parkinson's. Otherwise, the dopaminergic effects peripherally can cause nausea, it can cause vomiting, it can make the patient feel really sick. So levodopa is going to be converted into dopamine, but then you also have to have it combined with carbidopa. What does carbidopa do? Carbidopa is going to be a peripheral decarboxylase inhibitor. So basically prevents levodopa from turning into dopamine peripherally. Then when levodopa is able to get into the central nervous system, that's when it has its effects in treatment of Parkinson's disease. Now, carbidopa is going to remain peripherally. It doesn't cross the blood-brain barrier. Levodopa does cross the blood-brain barrier, but carbidopa stays outside. But when it's peripherally, carbidopa is going to prevent levodopa from having its adverse effects. We're going to talk about Parkinson's disease later on in the semester, but this is a really great example of how certain drugs cross the blood-brain barrier, whereas other drugs don't. Levodopa does cross the blood-brain barrier. Carbidopa does not. All right, now let's talk about hematomas. Here's a fun image of neurosurgery being performed back in the day. So back in the day, trepanation, we talked about that already with like the Incans and stuff, right? That image that I showed you at the onset of part 3 here. So trepanation was, it still is a treatment that can be used to relieve pressure after you have some sort of damage and inflammation to the brain, right? It can help prevent damage due to brain swelling and whatnot. So speaking of damage to the brain, something that's usually caused by trauma, different types of hematomas. And so the two major types of hematomas are going to be your epidural and your subdural hematoma. Epidural is going to be really fast. Subdural is going to be a slower bleed. Epidural is also referred to as a talk and die syndrome, where you have like, you get hit in the head by something. Maybe it's like an accident. Maybe you got into a fight and then you bust the middle cerebral artery. Sorry, the middle, oh my God, I can't remember which artery it was. Anyways, you rupture the artery and you start bleeding. It happens fast. You're like, you're conscious, you're lucid for a period of time, but the bleed gets so fast that all of a sudden now you decompensate and go into a coma. And it's a surgical emergency. You need to go in, cut open the cranium, and surgically remove the blood clot. That's what a hematoma is. So it's usually going to be due to head trauma. It could also be due to a person who's taking like blood thinners, like anticoagulants. And it's going to be due usually to skull fractures. We already talked about subarachnoid hemorrhages. That's going to be a little bit different. That's going to be due to a ruptured berry aneurysm at the circle of Willis. But similar types of symptoms. You get really bad headache. You might get nausea and vomiting. You might have your vision affected. You might also see hemiparesis, right? If it starts affecting the motor function. You might see speech changes if it's affecting Broca's and Wernicke's. And you definitely want to do a CT scan to see what kind of hematoma you're dealing with. With an epidural hematoma, when you look at it on a CT scan, and you're going to have to identify this on the exam because I'm going to provide you with radiographic images so you can diagnose if it's an epidural or subdural hematoma. Epidural is going to look like a biconcave lens. Okay, so very easy to spot on a CT scan. So it's got a biconcave lens shape. Whereas a subdural hematoma is going to have a crescent moon type shape. Okay, so if you see a crescent moon shape, that's going to be a subdural hematoma. That was, middle meningeal artery, not middle cerebral artery. So usually with a epidural, it's middle meningeal artery damage, and that's the talk and die syndrome. It happens really, really fast. Whereas subdural is going to be bridging veins. And usually it's going to be due to some form of like shearing stress. Like if you had like really bad whiplash and your brain kind of shakes in your skull, that can cause shearing stress and shearing damage that could damage the bridging veins. Epidural, usually it's going to be due to a skull fracture, some sort of head trauma like that. And it's going to be involving the middle meningeal artery. It could also involve the middle meningeal vein as well, but it's mostly going to be the artery. And again, this is talk and die. So you have your lucid interval, you're like, you think you're fine, and all of a sudden you decompensate pretty rapidly afterwards. And so if you were to remove the skull cap, right, and you're able to actually look at the blood in the brain, this is all this kind of like lightish color, that's all the dura mater, right? That's the thick connective tissue. And then this is an epidural hematoma, so the hematoma is going to be outside of the dura mater. Subdural hematoma, again, this is going to be lens shape. This image kind of sucks. It's not a really great illustration. It shows where it is, right? It's underneath the dura, but it doesn't give you like a nice crescent moon shape on this image. So if I were to give you a radiograph of a subdural, it's going to be like super obvious that it's a crescent moon shape. So just make sure you know that shape. There's a couple different types. Don't worry about the subtypes. But what's going on with subdurals, it happens slower, so it progresses slower. But the big fear is that you have increased intracranial pressure, and then you start getting herniations. And herniations are what kills the person. What happens with a herniation? Where you have one region of the brain entering into a compartment of another area of the brain where it's not supposed to be. So you have uncal herniations, where it goes through the tentorium. They call it transtentorial. The dura mater over here, it forms kind of like a tent shape between the cerebrum and the cerebellum. If you start getting a herniation of cerebrum down into where the cerebellum is, that's a really dangerous situation. So that can cause all sorts of autonomic issues. Right? The person could easily die from that. There's these transcranial herniation. That would be if it herniates outside of the skull. But then you have these other types of herniation, cingulate herniation, where it crosses onto the other side of the cerebral hemisphere. So the herniations are what kills the person. That's why it's so scary. Now, if a person has brain trauma, they're going to have increased intracranial pressure, or ICP, not insane clown posse, okay? So increased intracranial pressure. How do you reduce their intracranial pressure? You can give them mannitol. And mannitol basically is a diuretic. You also probably want to put them into a coma. So you can do a barbiturate-induced coma. So let's watch a video of a craniotomy real quick. Both of these cases, the patients survived. There's one that still had permanent neurological deficits after the surgery. But 10-year-old patient, head trauma, left frontal epidural hematoma. And then they did a craniotomy, so cut through the cranium of the skull. And so look at that. You see that really nice looking biconcave lens shape. So this is a classic presentation of an epidural hematoma. And there's your patient. You can see the bruise where the injury took place. And so now over there you can see that's the skull. So they retracted all the soft tissues, skin, muscle, all of that. And now they're going to be removing a portion of the skull as part of the craniotomy. And there's your hematoma right there. So it looks like a bunch of strawberry jam. Would you say strawberry jam?
Don't compare it to
And look at that pulsation. You see the pulsating?
Mm-hmm.
That's all the arteries. All the arteries in the brain. So look at the way he just removes that. It's incredible. So you have to do a surgical evacuation. You have to actually go in there and remove all of that coagulated blood. Yeah, it's a particularly gruesome video. The other one I'm going to show you too is also particularly gruesome. So now he evacuated all the coagulated blood, and now we're good to go. He's going to be able to close everything back up again.
How long does it take to heal?
I don't know what the recovery time is. I guess it just depends on the severity. If I remember correctly, this patient recovers. This is a 10-year-old kid, so he's pretty young. So if I remember correctly, he recovers. He gives like a little synopsis of the surgical outcome. Yeah, the bones. It's bones, you know.
What about the stitches? Do they have to remove?
If it's inside, if it's internal stitches, those are going to be absorbent. So there's actually stitches that don't absorb, but a lot of the stitches can be absorbed and they'll reabsorb. So 2-hour-long surgery. There was no complications to this patient. So this patient actually recovered, and they were discharged the second day after the surgical procedure. So absolutely amazing. Now this other video, if I remember correctly, now this lady, I think it's a woman, and she had permanent neurological deficits. Now this one's a little bit more exciting because it has a very pleasant soundtrack to it. So this is an older person, 83 years old. So, and this one is a subdural hematoma acute subdural hematoma. And she has, look, uncal herniation. So that's why she had some permanent neurological deficits. Look at that crescent shape on CT scan. So if you see something like that on your exam, that's exactly what it is, subdural. And you can see how everything now is shifting over, right? Look, that's the ventricles. Everything has been shifted over. So those are all herniations. So there's your skull. Yes, it is. It's Tchaikovsky. It definitely gives us some serial killer vibes. So that's the dura mater right there, the white stuff that he's about to peel back. Right, so he's cutting through the dura mater right now.
Trying to make it pleasant.
And there you go. That's it. Strawberry jam. Now this video is actually pretty cool too. You're going to see something happen. As soon as he evacuates it, you're going to see something happen.
It just slid off.
It slid right off, yeah. Now, Watch that right there. You see that? So you got a gusher. So that's an artery that got ruptured. I don't think that was the artery that caused the subdural hematoma, or it could be. But now he's going to go do an electrocautery. So that device that he has on the right side, that's an electrocautery device. So it's electricity and it burns the artery, and so it can like re-occlude it, right? So it stops the bleed. And so again, this is an older patient, so she's probably gonna have a harder time recovering from this compared to a 10-year-old kid, right? 83 years old. So 3 hours is how long it took. Patient remained intubated. After a month, the patient began, she had sequelae. So cranial nerve 3 damage, and she had right-sided paresis. So she actually was paralyzed from the incident. All right, sorry, Tchaikovsky, not anymore. So she did have hemiparesis after that and cranial nerve 3 damage. What would happen if you had cranial nerve 3 damage? Yeah, you wouldn't be able to move your eyes and? Huh? No. That would be cranial nerve 2. Pupils, yes. Yeah, so you wouldn't be able to constrict or dilate your pupils if you had cranial nerve 3 damage. Now let's close up talking about meningitis. Again, here's your layers of the meninges. Where do you find your CSF? Subarachnoid space. Beautiful. Where's this needle going into when you're doing a lumbar puncture? Oh, yeah, it's either between L3 or L4, but again, subarachnoid space, right? So you're going into the subarachnoid space. That's where you're getting your CSF out of. And if you're doing a lumbar puncture, why do you want to go between L3 and L4 or L4 and L5? Yes, the spinal cord. Where does the spinal cord end?
Oh, right there.
Like around L1, L2. And what's that tip called at the very end? Conus medullaris? Conus medullaris. And then the cauda equina comes off after that too. So you have the conus medullaris, then you have the filum terminale, which basically anchors the spinal cord down into the coccygeal joint, if I remember correctly. Anyways, not going to test you on that. But meningitis, I will test you on meningitis. So you have different types of meningitis. You have aseptic and you have septic. Aseptic meningitis, not really a huge deal. It can be pretty nasty, but usually the patient will recover, and you can give them drugs like acyclovir, right? So you can give them antivirals. You can get corticosteroids to reduce inflammation. What's the number one cause? Herpes simplex. So HSV2 is going to be one of the most common causes of aseptic meningitis. But the meningitis that I really care about is going to be this one, septic meningitis, and that's bacterial. Why? Because it is way more deadly. Bacterial meningitis can kill a person really, really rapidly. And how do you usually get it? You can get it different ways. You can get it if you had like a respiratory infection. The number one cause of bacterial meningitis is this guy, Streptococcus pneumoniae. That's also the number one cause of pneumonia. So a person who gets pneumonia, right, it could get into the blood. It could eventually get its way into the brain, right, and cause meningitis. And so that's one of the major causes. Another cause would be meningococcal meningitis, Neisseria meningitidis. And then Haemophilus influenza can also cause it as well. But the most important one, at least for this class, is going to be pneumococcal meningitis. And it can be very contagious, especially the meningococcal meningitis. There's actually a meningitis belt somewhere, I forget, in Africa. It's like around like the Sudan Darfur region, if I remember correctly. But there's like a whole area that has lots of meningococcal meningitis. Signs and symptoms. The biggest ones are going to be fever, right? Because it's, infectious. Nuchal rigidity, right? That means neck stiffness of the neck. And also photophobia might be one. Also, you might have a really, really, really bad headache. And by you will have a really bad headache. But nuchal rigidity is one of the major things that's involved in meningitis, especially for diagnostic purposes. If you were to do a lumbar puncture and look at their CSF, these are the things that you would find on their CSF to compare whether it's bacterial versus viral. Now, if it's a bacterial meningitis, bacteria love sugar, so your glucose levels are going to be reduced. Also, what white blood cell fights bacterial infections? It's your neutrophils, right? So you're going to have neutrophilia within your CSF. Proteins, you're going to see protein elevation in all the different forms of meningitis. So that's not really super high yield. Viral meningitis, glucose is going to be completely normal. But what kind of white blood cell fights off viruses? Lymphocytes. So you can see lymphocytosis in their CSF. And then you're going to do the Koenig and Brzezinski's test. And I'll show you that in a second. Other things that you might find too, if it's septic meningitis, you might see the CSF is going to look cloudy. Right? As the CSF comes out, it's not going to be clear. It should be clear, but it's going to be turbid and it's going to be cloudy. Let's skip forward here. Let's skip forward to the Koenig and Brzezinski's test. These are the ways that you diagnose meningitis clinically. So the Koenig's test is going to be this one up here, where you're flexing the patient's hip, right? So you're flexing their hip, and then you're trying to straighten out their knee. You're trying to straighten out their leg. And if they experience pain, that's going to be a positive Koenig's test. So Koenig, think knee. Well, both things kind of involve the knee, so maybe it's kind of tough. Think you're straightening out the knee with the Koenig's test. Brzezinski's test is a little bit different. You're putting your hands in the back of the patient's neck, so maybe B, back of neck, Brzezinski test, and you're trying to flex their neck forward. And if they experience pain with flexing the neck forward, and then they also reflexively bring their legs up, flex their flex their hip, and then flex their knee, then you know that is a positive Brzezinski's test. I don't know. Have you guys seen a charger in here at all? Would have been where?
I don't know. Maybe my ass
I don't see any chargers in here. No, you're good.
Okay.
Great success. Yeah, you too. Take care. All right, so here's your meningitis signs and symptoms. Okay, so you get all sorts of things: fever, vomiting, headache, nuchal rigidity, etc. You want to treat this patient right away. You have to. If a patient has bacterial meningitis, you go hardcore on them. You want to give them broad spectrum antibiotics, either vancomycin, ampicillin, or ceftriaxone, and you treat them aggressively because they can die really quick with bacterial meningitis. All right, let's do a couple questions on quizzes, and then let's see if we can have some time for chapter 1. Sorry, guys. We'll do, there's 18 questions here, so we're not going to go through all of them. We'll get through maybe 3 questions, and then we'll switch over to chapter 1.
Was it
Brzezinski's
shows bacterial?
They both do.
Oh.
Actually, sorry. You would get those in any type of meningitis,
Okay.
whether it's bacterial. There's also fungal meningitis. I didn't bring that up in this class, but there's bacterial, viral, and fungal meningitis. You would get a positive Brzezinski's and Koenig's test on both of those.
These are just tests to find out.
If it's meningitis.
And
then you do a CSF test, right? Exactly. And then you do a CSF analysis. You can do culturing, see what the contents of the CSF look like. Oh, yeah. If it's bacterial, yeah. IV antibiotics, aggressively treating them. Because you want that person to live through it. And then again, they can still have permanent neurological deficits. Often they can lose hearing, right? They can even lose parts of their speech and whatnot. So it's a really nasty situation to be in.
What if you misdiagnose them? It's like false positive, like between bacterial versus.
If you misdiagnose them, you're probably going to kill your patient. Don't misdiagnose meningitis. Okay, what blood vessel supplies the Broca's area and Wernicke's area? Middle meningeal artery. Middle cerebral artery. I keep on getting those mixed up because middle meningeal artery is what causes, for the most part, your epidural hematoma. So middle cerebral artery, and if you're talking word salad, that's going to be Wernicke's aphasia. Okay. The anterior cerebral artery would be more like the prefrontal cortex, right? Even the portion of like the medial part of the cerebral hemispheres. Okay, let's do like, I think 3 more. Is the text too much for your phone?
Yeah.
Is it? Is it? That sucks. Try to do it on your computers from now on, I guess. So what's that condition called? That's Broca's aphasia. Again, middle cerebral artery also provides blood to the Broca's area. So if you had a middle cerebral artery stroke, could affect both of those areas. I was showing my wife these questions when I wrote them. She was like, "Are you allowed to write stuff like that?" Yeah. Locked-in syndrome due to pontine damage. Excellent. Good job. That was an easy question. That was a softball. Let's do, I think, 1 more. So what's that called? Bell's palsy. Good. Another softball question. I hope most of you guys got that one right.
Is that infection like going to be what the hints on that one? That you come back with an infection and then all this happens?
Yeah, infection that preceded it, and then the inability to close the eye, right? So if the upper quadrant of the face is affected, then you're thinking Bell's palsy. I'm going to end it there. You guys do the rest of the questions on your own time. I just really wanted to do those 4 questions. Proud of those ones. Anyways, let's switch gears now and let's get into chapter 1. Thanks for your patience, guys. I know that there's been several changes already in this class, but, you know, we're sort of on track still. Oh, anyone like Hieronymus Bosch? Hieronymus Bosch is this amazing painter during the Renaissance period. His paintings are incredible. If you look him up, he'll have these massive like displays, and like all these little people doing all these crazy things. He had like it was like the Garden of Infinite Delights, if I remember correctly, and it showed like all these people doing wacky stuff. And then he'll show like depictions of like people in hell, like getting tortured by demons and stuff, and all this wild, wacky stuff. But I love this image in particular because, like, what the heck is going on here? First of all, this guy's like getting neurosurgery, and then you got this lady over here, and she's wearing a book on her head or something. And like, would you really trust this dude over here with the, is that like a funnel or something on his head? Like tinfoil hat or something? I don't know what's going on there, but fun stuff. This is Removing the Stone of Madness, painting by Hieronymus Bosch. So here's an overview of chapter 1, part 1. We're going to talk about the neuron, the structures of the neuron, what a neuron is made up of. We're going to talk about the supporting cells of the central nervous system and peripheral nervous system, your glial cells. Okay, glial cells are all the other cells besides neurons, right? You got your astrocytes, you got your, what else? You got your microglia, right? You got ependymal cells, you got your Schwann cells, oligodendrocytes, all that stuff. We're going to talk about the reticular theory versus the neuron doctrine. The neuron doctrine is the one that actually was proven true, and that was developed by Cajal, Dr. Cajal, who's also an artist. He was like the first one to do all those cool like little neuron drawings from back in the 19th century. We're going to talk about different staining techniques. So Golgi staining versus Nissl staining versus Cristal violet staining. We're going to talk about very, very briefly, just a super brief introduction on the myotactic reflex, because we're going to talk about reflexes later on when we get into motor. Sensory and motor, I'm trying to think where I'm going to put it in, but we're going to do reflex hammers on ourselves. So I'm going to teach you guys how to do all the different reflexes later on this semester. So I'm going to borrow my colleague. He's like got a big box full of reflex hammers. So I'm going to bring that in. We'll all do it together. But this will be a very brief introduction to what's going on with that, with like a patellar reflex. We're going to talk a little bit about genetically engineered viruses that can help to allow visualization of neurons and their, channel, their like synapses and all that. Calcium imaging, optogenetics, and then we're going to talk about the major divisions of the nervous system and a little bit of genetics in neuroscience. Again, this is not a genetics class, but there's going to be some situations where genetics do come up, unfortunately. Anyways, so what's a neuron? Neuron's going to be one of the functional units of the brain, right? So it's going to be what makes up a lot of your brain parenchyma. And they're going to be very varied in shapes and sizes. So you're going to have like bipolar neurons. You're going to have pyramidal neurons that are shaped like little pyramids. So you have all sorts of different types of neurons depending on what their function is. Again, you have glial cells. It's referred to either glia or glial with an L. And those are going to be all the supporting cells of the nervous system. What's a synapse? You guys already learned about synapses. Synapses are what? Where they connect, right? So it's going to be your presynaptic cell, you have your postsynaptic cell, and they synapse together. And then between those are going to communicate using neurotransmitters, right? And then this is really important, is your oligodendrocytes versus your Schwann cells. Central nervous system is going to be oligodendrocytes. And those are what produce your myelin sheaths within your central nervous system. On your peripheral nervous system, or in your peripheral nervous system, it's going to be Schwann cells. That's what produces the myelin sheaths. Now, there's a condition that affects oligodendrocytes specifically. I think we already talked about that in this class, but what is it? What was it? Do you remember the disease? Yes, perfect. Multiple sclerosis specifically affects oligodendrocytes. So if you were to do like a neuronal scan with like a CT scanner or an MRI, you would be able to see the white matter you would see like those demyelination plaques on a CT scan. So you'll see areas of demyelination. Now definitely know your neuronal anatomy. So receiving end, that's going to be your dendrites, right? Then signals are going to be sent down into the cell body. Soma is the term that we also use for a cell body in a neuron. Within the soma, you're going to find all sorts of stuff. You're going to find your nucleus. You're going to find a bunch of organelles like mitochondria. You're going to find lots of rough endoplasmic reticulum, Golgi apparatus. All that stuff is going to be within the soma of the cell. Those things all get produced like neurotransmitters and whatnot. And then those get sent all the way down the course of the axon through microtubules, right? Axons can be pretty dang long, right? Even like if you, like some of the first neurons that were studied were like squid, octopus, axons and neurons. They were very, very long. How do like neurotransmitters get sent from the cell body all the way down the course, like throughout the entire length of the axon? It's going to be these microtubules, right? And then there's these two carrier proteins that help to carry things down those microtubules. So we're going to talk about dynein, for example, and yeah, we'll talk about that in a second. So axons, super important for sending out signals. In order for a signal to maintain its integrity, you have myelin, right? So it acts as an insulation. And then again, oligodendrocytes, central nervous system. Oligodendrocytes can myelinate multiple different axons at one time. And that kind of makes sense too. Think about like within your brain. You got tons of, everything's kind of condensed right within your brain. And so one oligodendrocyte is going to be able to myelinate several adjacent axons. But when you get into the peripheral nervous system, you're not going to see that. Schwann cells are going to be 1-to-1. One Schwann cell per one axon. In between each of these myelin units, you're going to have nodes of Ranvier. What are you going to find within the nodes of Ranvier? Yeah, so it's a gap. So you get what? How does depolarization happen in a neuron? Yeah. What ions? Sodium goes where? Yes, sodium goes into the cell. That allows for depolarization, right? And then what causes the repolarization? Potassium goes where? Out. Yeah, exactly. So then you can repolarize the cell. And so that's going to happen at the nodes of Ranvier. So you're going to get all that taking place there. And then you're also going to have things like sodium potassium ATPase to bring, to reestablish the concentration gradient of sodium and potassium. And then at the very end, you're going to have your axon terminals. These black stained cells over here, that's silver staining. The other term for that is Golgi staining, named after Camille Golgi, who is another, one of the godfathers of neurology from the 19th century. So make sure you know all these different structures on your neuron. All right, so in terms of drawing these neurons, when they were first discovered, they were discovered through Golgi technique, so Golgi staining. And how did they do that? They used silver salts. And when you stain a cell with silver, it looks black. So if you look underneath a microscope, it's going to look super dark, super black. And so a lot of these images that you see from old neurology illustrations, those are actually not because they couldn't take a photograph of their microscope. They didn't have that technology at the time. So they hand drew what they saw underneath the microscope. And so we're going to talk about Cajal, Dr. Cajal in a second, or Cajal, because he's Spanish. And he was an artist as well. And so he would use Golgi staining to actually draw out all these neurons. And so Golgi and Cajal both are godfathers of modern neuroscience. These are the guys that really helped to pioneer the discovery and the different methods of staining these cells. So you got your dendritic arbors, because it looks like an arboreal type tree, right? It's got the branches that come off. The dendrites are the receiving ends. So each neuron could be receiving communication from tons of other axons, from other neurons, right? And so some are going to have more dendrites than others. So take a look at these cells over here. These are Purkinje cells within the cerebellum. Look at the size of that dendritic tree. Just absolutely massive in comparison to the cell body, right? And then the axon. So those are the dendritic arbors. And then you have the purple is going to be, and from your textbook, that's going to be the cell body or the soma of the cell. And yeah, depending on the cell type, you're going to see lots of diversity in the shape. Usually you're going to see, in terms of axons, you're usually going to see one axon per cell. And so as part of this image over here, when you see a little asterisk here, that's where the axon would go on for longer, right? So they didn't draw the full length of the axon. So these cells over here, they're going to have some pretty long axons. Compared to a little tiny bipolar cell, the bipolar cell might not have a super long axon. It might have a really short blunted dendrite, maybe a short blunted axon. So there's axon variability, in other words, right? Some cells are not really going to have much in terms of axons. Some are going to have a really short axon, and some are going to have really, really long axons. So there's going to be a lot of diversity. So let's do a little bit of history here. So the reticular theory of nerve cell communication. So there was two major theories in the 19th century that, they were trying to figure out exactly how the cells in the brain all work together to create some sort of, a neurological effect. And so the reticular theory was one of these. So here's the reticular theory. Continuous network of cells without gaps or synapses between the cells. So that's what the reticular theory was. So basically, you have just a giant clump of cells all working together. and it's all just a continuous network, no synapses. So maybe they were communicating through like gap junctions or something like that. That maybe was the original idea behind the reticular theory. Camille Golgi, brilliant guy. He's the one that was kind of behind the reticular theory, but although he was brilliant, this theory did not hold true. What did hold true, on the other hand, was the neuron doctrine. And the neuron doctrine was formulated by Dr. Cajal. So Santiago Ramon y Cajal was the guy who came up with the neuron doctrine. And so this is the idea behind the neuron doctrine. States that the basic signaling unit of the nervous system are separate, discrete cells with processes arising out of the cell body. And so you have one cell that does its own thing. It's producing its own neurotransmitters, and it goes off, and then it communicates with another adjacent cell, and then so on and so on and so on. And there's just downstream cascading effects from that type of communication. So neuron doctrine, we have one neuron doing one thing, communicating with another neuron that subsequently does another thing. And then this is the key factor in modern neuroscience and research, is that we were able to definitively prove that the neuron doctrine was true when we invented electron microscopy. So with electron microscopy, that's how we were able to actually see the neuron doctrine in real life. So let's close out by watching a little video. 241. It's a 3-minute video, so we'll watch through all of it through.
Where we pick our brains. Today we'll be talking about the neuron doctrine, one of the key principles in neuroscience. This video will cover the discoveries that enabled the study of neurons, the beginnings of histology, Franz Nissl and Nissl stains, Camillo Golgi, Golgi stains and his reticular theory, basic neuron characteristics, and Santiago Ramon y Cajal and his neuron doctrine. Cells are the building blocks of all life. Neurons are specific cells that carry electrical impulses and are the basic units of the nervous system. But before scientists could analyze the interactions between neurons, they first had to find ways to study neurons, which are extremely small and delicate. Once the compound microscope was developed in the 17th century, scientists could properly view neurons, and to preserve the structure of neurons, scientists would immerse brain tissue in formaldehyde to harden it, and cut the tissue with a microtome, which cuts extremely small slices. Thus began the study of histology, the microscopic study of the structure of tissues. However, histologists could not properly distinguish between individual cells. German neurologist Franz Nissl found a way to selectively stain a cell's nucleus and the surrounding area using cresol violet. These clumps are called Nissl bodies, and the stain is called a Nissl stain. Nissl stains can help distinguish between neurons and glia, which support and nourish neurons, as well as identify the arrangement of neurons. This arrangement of neurons in the brain is called cytoarchitecture. Later on, Italian histologist Camillo Golgi used a silver chromate solution to create the Golgi stain, which focused on the neuronal cell body. Golgi stains help determine the definitive characteristics of neurons, including a central region which contains the nucleus and thin tubes that extend from the center. We call the central region the soma, and the thin tubes that radiate from the soma are called neurites, which can be either axons or dendrites. Somas usually have one axon, which carry the output of neurons. On the other hand, numerous dendrites extend from the soma and receive the inputs of neurons. These discoveries from Golgi stains resulted in two opposing theories, one from Golgi himself and the other from the Spanish histologist Santiago Ramon y Cajal. Golgi developed the reticular theory, in which neurites of different cells form a continuous reticulum, or network. Cajal, however, argued that the neurites of different neurons are not continuous with each other, and communicate by contact, not continuity. This idea could be related to cell theory, which states that all living things are composed of one or more cells, the cell is the basic unit of life, and new cells arise from existing cells. This concept that cell theory also applies to neurons is known as the neuron doctrine. The scientific evidence that followed heavily backed Cajal's neuron doctrine, propelling the idea that the neuron is the basic unit of the nervous system, which we will learn more about next week.
Yep, we'll learn a bit more about that next week. Exactly what she said. All right, guys. So, come on, stop. All right, guys. Do you have any questions? Cool. All right. Rock and roll. Well, I'll see you all on Tuesday. So have a wonderful weekend. And then we'll continue on. We'll finish up with chapter 1 next week. And then we'll begin also with embryologic development as well.